So welcome to this series of webinars run by Apt UK. I am Malik, I'm a consultant cardiologist, and this section will be on COVID-19 and what you need to know as you're applying to medical school. So let me share my screen. So I work at Imperial College London, and I thank Apt UK for the opportunity to tell you about this. I also work at One Welbeck Heart Health. So what is the problem, what is the solution, and how has medicine changed is what I'll be dealing with today. So SARS-CoV-2 is the virus, COVID-19 is the disease. Severe acute respiratory syndrome is caused by a coronavirus, which has now spread throughout the world. If you look at that YouTube link, I've got the slides from there. It's very useful, slightly out of date, but very useful. So I'll try and update that during this presentation. So what it's not is Chinese flu. Of course, people attach labels, and once it's in the popular culture, Spanish flu, which occurred during the First World War, had nothing very much to do with Spain, but the name has stuck. So this might end up being called Chinese flu, but it's a global, worldwide problem. It's not really bat flu. The bats themselves weren't infected or affected. And it's not just the flu, because the flu is quite benign compared to what COVID-19 disease can do. It is a coronavirus, and coronaviruses cause common colds, but occasionally they can get a lot more vicious. So if you remember back to SARS, those of you who are old enough, which may be none of you, then it went from a bat reservoir to a civet, which is a small animal, and then jumped to humans. And those who remember MERS, Middle Eastern Respiratory Syndrome, that came from bats into camels and stayed in camels for a very long period of time before jumping the species barrier and getting into humans. And COVID-19 disease caused by SARS-CoV-2, again, probably had a bat reservoir, went through a pangolin, which is a small animal, unfortunately loved by the exotic animal trade. And therefore, if that's carrying a virus very similar to SARS-CoV-2 that's gone into humans, then that is spread because it travels around the world in crates. So it's worth comparing COVID-19 disease, and I think this data, which came from that YouTube video as of February, but actually, although the number of deaths, of course, around the world is much higher, the average death rate is probably similar at about 2.5%. That is very mild compared to SARS, which had an almost 10% death rate, but with a smaller number of cases before it burnt out. MERS, with an even smaller number of cases, but an even higher death rate. And of course, the Ebola crisis, which had it gone across the world, really would have caused significant death. So how does it spread? Well, it's like a cold virus, and therefore it's going to spread through the air, through aerosol. And so small droplets entering into your lungs will cause you to be infected. And on average, about 5 days later, you'll get symptoms, but it can be much longer, up to 3 weeks later. And of course, you may have no symptoms at all. It's not clear whether young children get infected and don't get any problem most of the time, or get infected and may not get infected even. So it may be that they're not even catching the disease. Of course, we now know that it can cause a very severe syndrome in some children that are prone to it. The other number that you will have heard of is the R0. The R0 is how infectious it is. So an R0 of 1 means that one person infects one other person. An R0 much more than 1 means a highly infectious disease that is going to spread. Polio, I think, sits at 3 to 4, and luckily there's a vaccine. This sits at about 2 to 2.5, which is higher than common flu and cold, but lower than some. By affecting the R0, by spreading yourself thinner, then you might be able to reduce the number of people infected, and that's how the measures for public health have been put in. And there are the occasional super spreaders that for some reason are shedding a much higher viral load, and therefore could spread to many more people. And there's a feeling that this might have happened in northern Italy. So how do you make a diagnosis? Well, it's a swab at the back of the throat and up your nose. And if it didn't hurt, they didn't do it properly. It has to be really scraping the back. Even when you've scraped it properly, the sensitivity is only about 70%. And so you may have to keep on repeating swabs if you really suspect the disease. The alternative is an antibody test. Now, the antibody test is not as validated, but it's faster to do. So you have your infection, you have your symptoms, you even begin to recover. The antibodies are starting a bit later. Initially IgM, the response then wanes by about 3 weeks, and then starting at about 2 weeks, an IgG response. The problem is, what happens 3 or 4 months later? If you have antibodies in your system, then okay, you were exposed to the virus unless there is a cross-reactivity with other viruses. If you did not have any antibodies, it may be you had the antibodies and they've now disappeared. It may be that you never had the infection. And even if you have the antibodies, it's not clear whether you're immune from the disease. So it is difficult to be absolutely certain about what the antibodies mean. There are a number of different tests available, all of which follow the similar pattern. So it's whatever's available in your locality that will decide what antibody test you get. And of course, as I put the caveat on, no one knows exactly what it means. So what about treatments? Unfortunately, there really isn't one. The chloroquine story has blown out now. I don't think it's an effective treatment, and I certainly wouldn't be giving it to my patients. The antiretroviral drugs are part of a trial, certainly I think worthwhile considering. And one small recent study suggesting that dexamethasone, a steroid, could be given to high-risk patients to reduce their lung inflammation. The main care is supportive, whether that's at home with you taking water, getting some bed rest, taking regular paracetamol, whether it's watching your parents or your grandparents very carefully, maybe having an oxygen monitor at home that tells you when their oxygen levels start to dip, which is a time to take them to hospital. And then once in hospital, providing rehydration, providing the paracetamol, treating secondary infections, and most importantly, giving oxygen when it's required. And the oxygen may be nasal prongs, it might be a CPAP machine which forces oxygen into the lungs, but most likely if you're deteriorating, it's the intensive care unit and what may be a prolonged period of ventilation. So better to prevent. And so in hospital, we're isolating people with COVID so that we don't catch it from them, they don't spread it to others. And the isolation really works. We've noticed dramatic drops in other infection rates in hospitals. So MRSA and Clostridium difficile are very rare in the hospital now because of the immaculate hygiene conditions and the isolation. If you don't isolate properly, you get a cluster in your hospital. And in a hospital in particular, that can be a disaster. It can close a whole ward, a whole wing. It might even close the whole hospital. So try and stay away from people. You know that the current advice is about 2 meters away. That's because perhaps if you just talking, then the droplets will have fallen to the ground by 2 meters. If you sneeze, it'll go a much longer way. So the 2 meters is a rough guide. The further away from someone you are, the less likely it is that they're going to infect you or you're going to infect them. But in addition, it can survive on surfaces for many days. So on plastic or cardboard, perhaps 3 days. So you've seen videos of people taking their shopping in, quarantining the shopping, cleaning it down. Certainly mail could be quarantined, or you take the outer packaging out and throw it away outside and then wash your hands. And remember, washing hands is singing happy birthday twice. It's a lot of scrubbing, and there are some videos available on how to do that properly. It's not just a quick dip in a tap. So prevention also means avoiding spreading. Obviously, you're not going to travel to the center of an outbreak, but actually, you should not be traveling out of an outbreak area because you could well be spreading the disease across continents. You're going to stay away from crowds, which the UK seems to be particularly bad at doing, and you're going to stay 2 meters away from anyone. In addition, of course, there's been the self-isolation of many people so that you can ensure that those who are particularly at risk don't get involved. For healthcare workers in the hospital, then you have surgical masks, gloves, long sleeve gowns, eye protection, and the sort of respirator or mask that you use depends on which area you're in. The best ones are probably hoods which ventilate the inside of you, pushing air outwards and have a filter. But below that is the N99 mask, or FFP3, and below that is the N95 or FFP2. Below that is what you see everyone wearing on the bus, which is an ordinary surgical mask, or even on the bus, just a scarf. Something is better than nothing. The main protection is of others from you if you're wearing just a scarf or an ordinary surgical mask, but obviously something is better than nothing. So I want to take you through some data and how you look at data, because part of you is a scientist and you have to involve yourself in how data looks. So here's a graph which is taken from this website, In Our World in Data, which is actually very good. And you can see that on the left-hand panel, the United States looks actually in pretty bad shape, with Brazil coming up behind. This is a linear scale of an increasing number of cases. But can you pick up the rate of change? The rate of change is actually on the log scale. And you can see that the rate of change is flattening out, but the change is still occurring every single day. And so you might be slightly more reassured by looking at the right-hand panel, but you have to look at both panels to actually understand the data fully. So what about these? These are death rates. And so you could see that on the left-hand panel, on the linear scale, on the right-hand panel, these look more similar, don't they? But although the death rate perhaps is flattening, in fact, it's still far too high in many countries. And you can see the waxing and waning that may occur. And you should, on this sort of chart, be able to pick up the next spike of deaths when it occurs. I don't think it'll be an if, unfortunately. So what about testing? There's been a lot about testing, and you can see some countries, if you look at per 1,000 of the population, the left-hand panel, are testing far more than others. But perhaps that's one measure. And so if you have a country that's testing many or more of its population, you might expect it to have a higher incidence, which is what some politicians would tell you, because you've picked up more. Perhaps another marker then is to say how many of your tests are positive. So you can see on the right-hand panel that New Zealand and Australia, over 300 tests for one positive case, which suggests that they're either testing lots of people or the wrong people, probably lots of people. Whereas in the United Kingdom, it's only 24 for a positive test. So that's either indicates that we're rationing the test to those most at risk, or that our incident rate is very high. Neither of those two is happy news, obviously. So what's the reason behind actually putting lots of protective measures in? Well, it's because without measures, you get a very high spike, and therefore the healthcare system may be over capacity. That's what happened in northern Italy. Whereas with protective measures, then you get a flattening of the curve. You may still get the same number of cases eventually, but the healthcare system can cope. And I think in the UK, we haven't had a massive use of the Nightingale hospitals. And although we went through a phase where every ward was looking like intensive care unit, we seem to have ridden it out. Could we have done better? Well, I think perhaps we could have actually put the protective measures in earlier and therefore flattened the curve even more, and that may have saved more lives. What has changed in medicine? Well, obviously the NHS is very much more appreciated by everyone, given that they were getting much closer to using it than they had been before COVID hit and when they were fully healthy. Telemedicine has really arrived, and I'm doing this on a Zoom call with you, but Zoom, Microsoft Teams, other products are available, are allowing people to actually do multidisciplinary meetings and consultations with patients with less face-to-face contact. There's a downside. You need to be able to actually feel a pulse perhaps, or listen to a chest. That's happening with much more difficulty. So telemedicine is here to stay, I think. In hospital, we're wearing a lot of personal protective equipment, PPE. That means that we find it harder to communicate. Even when we've taken it off in the coffee room, we're socially distancing. These are stressful environments, and that chat afterwards sometimes was helpful to bring you down from the stress. And that's happening less often. And our productivity is lower because you have to clean the operating theatre in between cases. That is very difficult, and of course takes time, and therefore you can't do as many cases. Dentists are finding the same. And of course there's no visitors in the hospital. Even when your loved one is dying, you may not be allowed in, and there's been some innovations about doing video calls at that strange time. But it's painful and it's different from before. So in conclusion, a lot of what we're doing is the same. Some of the problems remain. There's nothing changed about our hospital environment. We haven't got any new hospitals. the work is still rewarding, and perhaps even more rewarding now that perhaps you're more appreciated. The differences are that PPE is here to stay. You're going to be wearing a mask on a bus for some period of time, and in hospitals, we're definitely going to be wearing masks walking around. We've got longer waiting lists, and I'm afraid I think there's a hidden spike of death coming. This is not from a second spike of COVID-19. This is from all those people with cancer, with heart disease, with other conditions that have been staying at home, that haven't had access to healthcare. There's also those people in the care homes where the death may not have been recorded as COVID, but their death has been hastened by the lack of care, the strange new environment, and perhaps even COVID without a test being available. So the total mortality in this year compared to last year will, I think, show a much higher death toll than we have appreciated up till now. Thank you.